Hi, I'm Ed Loftus. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota, and I specialize in taking care of patients with Crohn's disease and ulcerative colitis. And I wanted to talk to you today about how to use the biologic therapies more effectively. It's now been 20 years since we've had infliximab available for the treatment of Crohn's disease, and now we have at least 6 different biologics available for treating either Crohn's disease or ulcerative colitis, and these include infliximab and adalimumab. These are probably the 2 that are most widely used, and we have some other interesting molecules coming down the pike. Well, it's often a bit of a challenge as a clinician deciding which drug to use initially when you're using a biologic. I think most people agree that in Crohn's disease, that if a patient is steroid dependent, there's a role for biologic therapy. And in ulcerative colitis, similarly, if a patient is steroid dependent despite the use of 5-aminosalicylates, there's a role for biologic therapy. The challenge is which one to use first. And we still don't have great guidance on this, and there is no one right answer. In my own practice, I use a combination of several things. I look at the patient's age, I look at whether or not they have extraintestinal manifestations, whether or not they have fistulizing disease, whether they have a personal history of malignancy, and I just also look at how risk averse that patient is, and then I kind of put my patients in buckets based on that. So I'll give you an example. Older patients, so a patient over the age of 65, we know from previous studies that patients who are treated with the anti-TNF agents have a higher rate of serious infection with those. And so in an older patient, I'm much more likely to use a non-anti-TNF biologic option like vedolizumab or ustekinumab. That would be one example. Anyway, I think the other piece of this, though, is once you pick the biologic that the patient is on, is how do you optimize the use of that? And what we run into with all of the biologics is that there's an annual rate of loss of response of about 15 or 20%. And so when you run into that patient who's initially doing well, but starting to lose response clinically, having more fatigue, more diarrhea, more pain, more bleeding, what do you do? And I think what we've found over the years is that checking a trough level of the biologic is very helpful in sorting out how to manage that patient. And so if the trough level comes back therapeutic and the patient has active inflammation and there's no room to really maximize therapy, maybe that patient should be switched to a different medication. On the other hand, if the patient's level comes back low and there are no significant antibodies to the drug, then I would probably escalate the dose. And if the drug level comes back 0 with high levels of antibodies, then I would switch to a different medication altogether. Mayo Medical Labs has taken an interesting approach with our infliximab and adalimumab assays in that we do a reflex. So if the drug level is above 5 micrograms per ml, we don't do the antibodies because the patient has a pretty decent drug level and it's unlikely that antibodies are affecting that level. Whereas if the drug level is below 5 micrograms per ml, we'll go ahead and check the antibodies. And so it's a reflex test. It's a very affordable test. It's cost effective. Anecdotally, I've never had any feedback from the patient that their insurance company wouldn't cover the test, and so there's very little out-of-pocket cost for the patients. It's a pretty quick turnaround time as well, and all in all, we've been very pleased with the operating characteristics of both tests, and there'll be more tests in the future, so looking forward to seeing those roll out as well. Thanks a lot.